Our next speaker. Our next speaker is Professor Dr. Khaled Mohsin. Professor Dr. Khaled Mohsin, can you hear us?
Yes, Nur Alam, I can hear you.
Thank you. Professor Dr. Khaled Mohsin will give talk on optimum antiplatelet regime in IHD, including high bleeding risk patients. And he also gives some emphasis on the anticoagulant like Favinax. So, Professor Dr. Khaled Mohsin, you can start. You can share your slide.
Okay, thank you, Nur Alam. And thanks to BSCI, its President, General Secretary, Scientific Secretary, Office Secretary, and International Affairs Secretary for your untiring efforts to make the session successful. I'm just sharing the screen. Can you see my slides, please? Yeah.
Yes.
Okay.
The PowerPoint mode.
Yeah. I'm going the, yeah.
Okay. It's clear.
Okay. So as you have mentioned that the antiplatelet regime, or optimum antiplatelet regime is a very important aspect in treatment of ischemic heart disease, particularly in the setting of percutaneous coronary intervention. And as we all know that it is a double-edged sword, it has got its benefit for prevention of thrombosis and ischemia, but on the other hand, it can cause some harm leading to by causing excess bleeding manifestation. As we all know that the thrombotic risk after percutaneous coronary intervention, it has some patient factors like the prothrombotic characters, the thrombosis induced by the stent, and the underlying the atherosclerotic disease, which we tend to address it. What we mean by the dual antiplatelet therapy, actually the traditional antiplatelet drug is aspirin, but it has been supplemented by the P2Y12 inhibitors, and the combination is known as the dual antiplatelet therapy, which is aimed at reducing the thrombotic events in the setting of ischemic heart disease with or without PCI. And as I have already mentioned, that the risk of myocardial ischemia and infarction induced by the thrombosis, it can be addressed by the antiplatelet drugs, but the bleeding can lead to increased morbidity and mortality. This is a brief schematic representation of what we want to achieve by using the antiplatelet drug. Here we can see on the left upper panel that this is the stent struts, which are definitely, these are the thrombogenic substrates, and the stent has caused the disruption of the endothelium, and all this can lead to the platelet activation. The exposure from the collagen can lead to platelet adhesion, then the platelet aggregation, release of platelet factors, and activation of the coagulation cascade, release of growth factors from the platelets. These are all the things which can lead to the thrombosis, and we address the thrombosis by the antithrombotic drugs, which act by some different mechanism like the thromboxane A2 inhibition, the ADP, and the glycoprotein 2B3A inhibition. Sorry. And ultimately, the generation of fibrin is the ultimate common pathway, and the anticoagulants tend to decrease it. And Favinax is one of the newer antithrombotic drugs which directly acts on the factor 10A, and it is, as Dr. Nur Alam has said, that it is a very promising drug. The numerous trials has evolved from 1996, and this has involved several medications starting from aspirin is the basic drug, but regarding the second combination, the ticlopidine, Clopidogrel, Prasugrel, and lately ticagrelor, numerous drug has come out, and some drugs have very good amount of subjects, some has less amount, but all as aimed at reducing the thrombotic event as well as minimizing the bleeding episodes arising out of it. The first, in 1996, the ISAR trial has demonstrated that the dual antiplatelet, if it is, it has got advantages over aspirin, and which was at then combined with warfarin, but warfarin has not been used nowadays until there is a atrial fibrillation or a mechanical valve. The ticlopidine is the first drug which reduced the death and MI by 75 to 85% at 1 month, combination to aspirin plus warfarin. And the second generation phenylpyridine, Clopidogrel, came next, and it is still a very popular drug. And the ischemic risk and bleeding complication has been investigated by many clinical trials. I would not go into the details. The Professor Park in 2010 has shown that the dual antiplatelet drug more than 12 months after the initiation is not more effective than aspirin. And there are numerous studies that the DAPT study is a very landmark one. It has shown that if the P2Y12 inhibitor definitely lowers the risk of MI and stent thrombosis compared to placebo at 18 months. But on the other hand, it increases the statistically significant incidence of bleeding and mortality. These are the other trials which have shown almost similar results. STOP DAPT, SMART DATE, DAPT STMI, these are all the very well-designed trials. Let us look at aspirin, which is the basic drug in our armamentarium of dual antiplatelet. It is it manipulates the cyclooxygenase pathway 1, and it is reduces the generation of thromboxane A2, which is a very important agent for platelet aggregation, and it also causes the reduced incidence of vasoconstriction and endothelial dysfunction. And as it is an anti-inflammatory drug, it suppresses the inflammation as well. This is a schematic diagram of the P2Y12 receptor. Here we can see that we block mainly the P2Y12 receptor. We mediates by the cyclic AMP, and also the other receptors are there. In those receptors, calcium does play a role in platelet aggregation, but the most important receptor is P2Y12. These are the three drugs which are commonly used as the second drug added to aspirin. The first of all, the most commonly used one is Clopidogrel. It is a phenylpyridine derivative. It's a prodrug. We cannot reverse it very easily. It has got a hepatic metabolism. Half-life is 6 hours. The loading dose is 300 to 600 milligram. Maintenance is 75 milligram. Onset of effect is a bit delayed, and duration persists about 3 to 5 days. But on an average, it is about 5 days. It requires a once daily administration. Prasugrel is also a phenylpyridine derivative and a prodrug. It is metabolized by a separate cytochrome enzyme. The half-life is a bit more prolonged. Loading days is 60 milligram. Maintenance is 10 milligram. But in Japan, they are using the lower doses. It is relatively faster acting drug. The action is also prolonged and is a single administration. Ticagrelor is the newest kid on the block. It is an active drug. It doesn't need biological conversion, and it is reversible. hepatic metabolism, action is almost half-life is almost same. It requires twice daily dose. Loading is 180 milligram, and it is in Japan lower doses are used. The onset is a bit fast. Duration, it wears off a bit early, so it has got advantages in ischemic setting, but the main disadvantage is it requires twice daily administration. These are the use of platelet in different antiplatelets in different subsets of ischemic heart disease. First, if we start from stable coronary artery disease, we don't use antiplatelet unless the patients are going for a PCI. In acute coronary syndrome, those who are medically treated, if there is a high bleeding risk, we can use the drug like it is a class 2 indication, and if if there is no active bleeding risk, then we can continue the drugs up to 12 months. It may be aspirin, ticagrelor, or aspirin clopidogrel, and after that, if it is a class 1 indication, and after 12 months, it is definitely a class 2 indication. It can be done. In case of acute coronary syndrome, it is it has been already mentioned, and the next common one is the post PCI patient. There are two groups of patients. Number one is the those who have stable coronary artery disease, and if they have a normal bleeding risk, we can 6 months of dual antiplatelet, and then the next 12 up to 12 months, it is definitely a lesser indication. But if the patient has got a higher bleeding risk, we can stop the drugs, one drug at 1 month, and then the 3 months is enough. And in case of acute coronary syndrome, we need to in acute coronary syndrome, in a bioabsorbable vascular in scaffold, it is more thrombogenic, so it is the 12-month therapy is recommended. And in the patient with high bleeding risk, the 6-month therapy is recommended in the setting of acute coronary syndrome. And if there is no high bleeding risk, the 12-month therapy with the combination, it's a class 1 indication, and beyond 12 months, it's a class 2B indication. These are the drugs which are commonly used. That the ticagrelor number 1, it's a class 1B, prasugrel class 1B, then the P2 is a general indication class 1A, clopidogrel loading, it's a class 1A indication. To minimize the bleeding, the radial route preference is a class 1 indication. Aspirin dose, lower dose is a class 1 indication. Addition of PPI is a class 1B indication. We need to switch over from one DAPT to another. It's a class 1B indication. It's according to the need of the patient. And the duration up to 12 months is a class 1A indication. Then in cases of the setting other than coronary stenting, prasugrel should not be used. That is very important. Unless the coronary anatomy is known, it is a class 3. That means it's a contraindication. And it is a another thing is that in non-cardiac surgery, within the first month after stent implantation, the dual antiplatelet should not be disrupted. This is a class 3. That means it's a contraindication. This is a summary of the previous recommendation. the USA and the European, this American College of Cardiology, European Society of Cardiology, no high bleeding risk, we can go for 12 months, and the high bleeding risk up to 6 months. This is the ACS setting, and stable coronary artery disease, the normal bleeding risk 6 months and high bleeding risk 3 months. It is the Japanese guidelines, it is almost similar. There are some trials comparing the efficacy of antiplatelets. It has shown that the Prasugrel is superior to Clopidogrel in reducing ischemic events, but there is significantly high bleeding with use of Clopidogrel. The Plateau trial compared ticagrelor with Clopidogrel. The ischemic events is less with ticagrelor, but increased in the bleeding risk compared to Clopidogrel. There are some other studies as well. The monotherapy of antiplatelets, it can be aspirin or a P2Y12 inhibitor. The Capri study, it has shown that Clopidogrel is relatively better than aspirin in patients with ischemic stroke, MI, or peripheral artery disease, in terms of reduction of MI and vascular death, but GI bleeding was almost similar. And some other studies also reveal the same findings. Let's recapitulate the patients who are at increased risk of thrombosis after stent implantation, and they require definitely the high longer duration of DAPT. There's the who has previous stent thrombosis, the last remaining patent artery stented, diffuse multivessel disease, CKD, more than 3 stents, more than 3 lesions, bifurcation with 2 stents, total stent length of more than 60 millimeter, and the treatment of chronic total occlusion. There is a renewed interest among now about the platelet function testing to find out whether the patient is partially or wholly resistant to Clopidogrel. But it is the studies so far has not recommended conclusively. There is the one big trial, the Antarctic trial. It has found that 45% patients are being undertreated or overtreated for the risk of Clopidogrel resistant, but only in 6 to 12% of the patient, there is a genetic background of this dose, but it has got only when there is a recurrent ischemic event, only in that case it can be considered. Otherwise, it is not routinely recommended. And another contentious issue is the concomitant use of proton pump inhibitor and DAPT. Proton pump inhibitor and H2 receptor antagonist are beneficial in patients receiving aspirin. Clopidogrel and PPI, they are metabolized by the same cytochrome enzyme, and there is a suspicion that there is reduced metabolic activation of Clopidogrel, and among PPI, omeprazole.
Sir, we are in short of time.
Yeah. Just time. Omeprazole and esomeprazole have the highest interaction, and the pantoprazole and rabeprazole has got less interaction, and there is a H2 blockers, they don't have much interaction. These are the scoring. These are the 3 scores which we use for calculating breathing: the precise DAPT score, the DAPT score, and the Paris score. If the precise DAPT score is more than 25, it is the patient bleeding risk is high. We go for a shorter duration, and the DAPT score, it ranges from -2 to 2, and 2 and more predicts high bleeding risk, so we have to be careful. And interruption of dual antiplatelet for a non-cardiac surgery, we should not interrupt within first month, but after 6 months it is relatively safe. And the combined oral anticoagulant and antiplatelets with patients with mechanical heart valves and atrial fibrillation. In patients with atrial fibrillation, 20 to 30% have a concomitant heart disease, which requires PCI. The triple therapy with vitamin K antagonist is associated with more bleeding compared to dual therapy, and stent thrombosis is not also much reduced. The Pioneer atrial fibrillation study, they have concluded that there is dual therapy with a direct oral anticoagulant with a P2Y12 inhibitor is better than triple therapy with warfarin. These are some trial which has also showed that longer anticoagulant therapy is harmful for the patient. And this is a schematic diagram in a patient with high bleeding risk. This is the bleeding triple therapy for 1 month, then dual therapy with 1 oral anticoagulant and 1 preferably clopidogrel for 6 months, and then monotherapy for 1 month. And for high bleeding risk patient, the triple therapy may be shortened up to 15 days. And in European guidelines also, that it has recommended the triple therapy for 1 month, followed by.
Sir, we have to conclude our session, sir.
Yeah. Just let me finish. There are some factors which, these are the predictors of high bleeding risk. This is the slide I want to show, that the more efficacious drug, Prasugrel, causes more bleeding. We have to keep in mind the aspirin is less efficacious, causes less bleeding. So we have to choose very judiciously. So we have to choose the Hasbled score and the other parameters. And if there is a bleeding, we have to act accordingly. So we have to, with this, I want to conclude that the dual antiplatelet therapy is a double-edged sword. It's mostly beneficial, but we have to find out the appropriate composition. We have to calculate the bleeding risk of the patient, and we have to avoid thrombosis as well as avoid excess bleeding. Thank you very much.
Sir, thank you, sir. Thank you for your excellent presentation. The last one question for the audience, that recently Fondaparinux is introduced in our market, sir. Can you please tell when we should use that?
Actually, Fondaparinux is an anticoagulant, and Fondaparinux has got a very unique property that it is directly acting on its factor 10, and it inhibits the factor 10A. And it is in this COVID era, it has attracted our attention. But regarding its position in the guidelines, I think it is a competitor for low molecular weight heparin. Low molecular weight heparin, it is an injectable drug. It can be given once daily, a very good safety profile, and I think it will be very good addition in management of post PCI patient as well, because it is a single dose, and it is a very promising drug, but it is too early to make a comment that whether it will replace the other parenteral anticoagulants which we are more experienced in using at present. But we are very hopeful about this new molecule. Thank you very much.
Thank you. Now